Welcome. Thank you so much for taking time out of your evening and coming and spending some time with us. As mentioned, I'm Julie DiNuoscio. I am a licensed professional counselor working at Emma Schmidt & Associates, and this is Jack Copley. I'll let him tell you his credentials.
Ooh.
You're so fancy. I don't know them all. He's a fancy man.
Glad I got through the door. Yeah.
Yeah, so if
you
would
want me to
explain,
go
yeah,
first?
go
Sure.
ahead and explain your credentials,
Yeah,
just 'cause I don't know them all.
Yeah. Hey, I'm Jack, and I'm a licensed marriage and family therapist. Here in Ohio, it's called an independent marriage and family therapist. I'm a certified sex therapist with a group called ASECT, and that stands for the American Association of Sexuality Educators, Counselors, and Therapists. So you can guess why we say ASECT. And then I have a doctorate of ministry and pastoral counseling from Louisville Presbyterian Seminary, and I teach sexuality there every couple of years. Teach a course down there. So.
Yeah, awesome. So that's just a little bit about who we are. Our practice, we focus on an array of different issues, anything from vaginismus, erectile dysfunction, to individuals who are survivors or partners of cancer, people who are just dealing with intimacy and relationships in general, and how to communicate. How do we talk about sex? What do we do? So we see a wide variety of individuals at our practice, and so if you have any questions at the end about how we can be a support to you, we'd love to answer any questions that you might have. But just to go ahead and dive in, Jack, I will let you begin.
I don't know how many of you are familiar with Masters and Johnson, but they are kind of the first bigwigs to hit the field of human sexuality. Their work was done primarily in the 1960s, and they're partially most famous for several things, but one of the big things they're famous for was they were the first ones to come across with a sexual response cycle. They were the ones to quantify it and observe it and study it. And they studied just hundreds of different people, and they actually watched them masturbating is how they did their work. So an interesting 9-to-5 job. So they watched people having sex, usually by themselves, and they came up with these phases of the human sexual response cycle. So you'll see that here. Here on the left of either screen is excitement, and then that goes up into plateau, and that's, the pleasure's increasing, and that'll go for a while, and then it bumps up to orgasm, and then there's resolution. And they were the first to really bookmark all of those phases and to kind of lay that out. And then, some years passed, and Helen Singer Kaplan was observing, and she said, I think we've missed an important element here. She was one of the students of Masters and Johnson, and she was the first to add desire on there. Nobody had started with desire. So she added desire, she changed plateau to arousal, and then to orgasm, and then later people started also talking about satisfaction. Were people satisfied with that sexual experience? So if you want to look at it, it also now is very popularly just kind of merged together into one diagram. The Masters and Johnson and the Kaplan model are merged together. So you can see it like this. The first one here, it's kind of like two lines together, but you see desire happening in parentheses, like that's presumed that'll happen first. And then we'll start moving toward arousal, and that'll get larger, and that'll increase until you plateau, and then boop, there you go into orgasm. And you'll notice there are two lines here. So the first orgasm is more for male, and then for female orgasm could be multiple orgasms. And again, that is not pressure, that's just possibility for women. They've lucked out with more orgasm there, and then resolution. Well, what's interesting about this is it became widespread, this model, and in fact it became the model of human sexuality. And it does have its benefits. We do have, can we go back?
Oh, sure.
It does have its benefits because it does give us names. It gives us ways to quantify what's happening. And when there's a disturbance in the force, so to speak, when there's something that's not quite working the way we want it to, it gives us a way to break that down and to know where the problem might be happening. For example, somebody maybe is on androgen blockers. They're trying to shut down all testosterone in the body to keep prostate cancer from spreading. That's a common thing to be on an androgen blocker. So desire is going to tank. So somebody's having low desire, that's going to be one of the areas. Arousal, let's say somebody did not have very maybe there wasn't a lot of nerve sparing in the prostatectomy when they had their prostate either partially removed or totally removed. They're going to have problems with erection. I'm thinking more from the male perspective here, so there are going to be problems with arousal. Orgasm difficulties, what's interesting, a lot of times with colon cancer, when there's been a removal there or some kind of surgery with the colon, it can affect the muscles in the pelvic floor so that they're chronically tense. And when the person has an orgasm, it's like they've had a swift kick in the groin. So that's another area. And then with resolution and satisfaction, just sex in general can feel less satisfying. Resolution, I don't hear many problems with around that with cancer. If any of you here know and want to raise your hand and share your information too. Resolution problems tend to be more with medications like the PDE5 inhibitors like Viagra, Cialis, when a man does not lose an erection after 4 hours. That's actually a real problem. If a man does not lose an erection after 4 hours, then the tissue in the penis starts to break down. So it's not just I know we sometimes get a joke about that, about a man not losing an erection, but that is a real problem. But as beneficial as this is in naming, the flip side has been that it is also oppressive. Because what we noticed is once we started having names for this, and it not just became normative, but became the norm for how sexual functioning became viewed, when people started to vary from this, suddenly all these dysfunctions started arising. Suddenly now there's premature ejaculation. Suddenly there's delayed orgasm. Suddenly there's no orgasm, and that's a problem. So what this came to be is something of a way for people to feel less about themselves or to feel like something was wrong with them if they didn't match this model. There was an interesting study done called the Height Report. Have any of you here heard of the Height Report? I had not before going into the field of sex therapy here. The interesting thing about Masters and Johnson as opposed to the Height Report, the Masters and Johnson study really was using state-of-the-art technology. In fact, I feel like it was so state-of-the-art that it would still be state-of-the-art today. For example, they were using plastic dildos for the women participants with cameras inside so that they would monitor the expansion and contraction of the vaginal walls. They could monitor when secretion was happening, vaginal fluids, that sort of thing. I feel like that would still be state-of-the-art today. But the only women they allowed into the program, into the study, were women who could orgasm through penetration alone, which from the get-go excluded 70% of all women. 70% of women need either total clitoral stimulation or partial clitoral stimulation to achieve orgasm. So they were out of the study from the get-go. The Height Report was very interesting because the Height Report was a massive study also. It just didn't get as much airplay of women and women's sexual preferences, and they included all women in the study, regardless of how they orgasmed. And what they found was much different than what Masters and Johnson described here. For the women in that study, sexuality came out to be more of the women saying, we wish everything in our life could be sexual. That it wasn't just this time frame that was sex. Maybe when we go out to dinner and look in each other's eyes, maybe that's foreplay. When we're holding hands and walking down the street, maybe that's also a sexual experience. When we come together and our bodies are touching more in an intimate way, what they found was, maybe their partner orgasmed before they did, but nobody worried about it. They were like, oh, well, that's good for you. Now it's your turn. What might feel good for you? Nobody was calling it premature ejaculation or delayed orgasm. It was just, what do we find that feels pleasurable and does it feel good to us? So what we're finding now is when we have this model and it starts to feel oppressive, is that people can start to feel like something is wrong with them if they don't match this model. And if people can let go of the pressure to match this A plus B plus C for X amount of time until we both reach this X amount of pleasure, if they can let go of that being the ideal of the only acceptable form of sex, and can broaden their definitions of sexuality and just be with their partner, their general satisfaction around sex tends to go up. I know I'm here to talk, and Julie's here to talk, but I feel like I just talked a long, long time. Does anybody have any questions so far on any of that?
Can you talk about what some of the drugs that the women may take for, say, things like breast cancer would do in that entire cycle? Like you discussed some of the implications of it.
Yes, you're an advanced student. If everybody could not hear, she wanted to know what some of the drugs that particularly women take for breast cancer, what it can do to the cycles here. We're going to talk about that some more in a minute, and we want to come back, but you're absolutely right, especially some of the drugs that are blocking estrogen can change what's happening in the vagina and the genitals around elasticity, lubrication, that sort of thing, and we're going to come back with some specific techniques around that. What I want to emphasize, though, is what's happening. Let's say a woman does have a change in her estrogen levels and it's diminishing or changing sexual functioning and it starts to vary from this. Does she then start to feel like she's abnormal and that's the end of sex? And those are the kind of specific changes we're going to be talking about and maybe ways to work around that or work with that. Any other questions? Thanks for asking. One other thing. After the height report around 2000, there were some other people who thought there's maybe even more lacking in this model. One is the studies tend to be based, and this model tends to be based around male sexual response, or I should say stereotypical male sexual response, where there's desire first and then arousal and orgasm. What we found for women is their sexual response can look much different, and that can look more like this. Julie, if you still want to push the button, you can.
Push it,
yes.
yes.
Okay. Thank you. This actually is not quite as complicated as it looks. If you think of it really like a big circle, that might simplify how this diagram works. This is the Bassan model that came out in 2001. What we found is actually women, only about one third of women have what we call spontaneous sexual drive. Men have about 10 times the amount of testosterone as women. And for men, not always, but stereotypically, men can just be ready to go for sex kind of just at the drop of a hat. Not always, and that's also can be oppressive, but more often than not, men can be more ready to go. Women, about 1/3 of them have that spontaneous sex drive, but really about 2/3 of women are more of a responsive sex drive. They're not going to be just automatically ready to go unless it's potentially in that first 6 to 18 months of a new relationship. Then they might flip into more of the spontaneous sex drive. But women might have sex for a lot of reasons. Maybe, let's pick one of the squares. We could start anywhere on the circle. And I actually wish these arrows went both ways, that it wasn't just one way around the circle. But let's say multiple reasons and incentives for investigating or agreeing to sex. That's interesting. Like, I might have a lot of reasons for just investigating whether or not I want to go towards sex. Back here, there might be non-sexual rewards. Maybe it's just to be close to her partner, emotional intimacy. Hey, maybe it feels good, it's relaxing, had a stressful day. Yeah, I'd like that. Lack of negative effects from sexual avoidance, meaning she's not getting a guilt trip if she says no, or being her partner's not angry with her, or whining if she says no. If those things aren't happening, maybe she'll be more receptive to having sex. Willingness to become receptive, sexual stimuli in the right context. Maybe that might interest her in having sex. Subjective arousal. And then sometimes in the middle, maybe there is sometimes spontaneous sex drive. Sometimes for women over the course of their period over a month, their interest in sex may peak at a different time. So multiple reasons for a woman to have sex that are different from this old model. And a lot of times this type of sex drive has been diagnosed as somehow inadequate or different because it's not that other model that became normative. One thing I do want to say is I'm not implying that if a woman says no, she means anything other than no. When a woman says no to sex, no means no. But what I am saying is where for a man, sometimes he might be ready to say yes. Or a woman who has more of a spontaneous sex drive might be willing to say yes. A woman with a more responsive sex drive might be more in, let's say, let's do a scale, 0 to 10. How in the mood are you for sex tonight? And she might say, I don't know, 4 or 5. Okay, maybe we could work with that. Let's see, maybe 4 or 5. If she's like 0, 1, no means no. So I just talked a lot again for a long stretch. Any questions? Yes, another hand.
Well, what's meant by subjective arousal?
Subjective is it's more contextual. It's more multiple reasons. It's not just always because I'm horny. What we've also found with this is because it's lightened up the pressure for women and it's allowing multiple ways to be normal, is the men are feeling a lot less pressure too. Men have this stereotype that they've got to be ready for sex all the time with any partner, regardless of their emotional state. And that's really ridiculous. It's a stereotype that's not healthy for anybody. And men, we find, actually can have a lot more of a responsive sex drive too. Great, another question.
Are you going to talk at all about like discoordinate sex drive and what that does like overall to a relationship satisfaction, self-esteem?
Yes, we'd like to touch on it. We could probably spend a whole hour and a half on that, but one of us will get it, and if we don't cover it adequately for you, we'll have Q&A at the end, so you can ask some questions again. But yes, this can cause a lot of disturbance between couples, especially if you have one partner who is more spontaneous sex drive and one who is more responsive. Also, in the first 6 to 18 months of a relationship, both partners are more spontaneous. And once that first honeymoon phase starts to die back down, especially for female partners, they can tend to go back to more of a responsive sex drive. And the other person can be a little bit like, what happened? Were you tricking me? What happened? Where did our sex life go? And it can be confusing for both people. The other thing to remember is no matter any two people you get to put together, there's always going to be a higher drive and a lower drive. So that mismatch, depending on how you communicate, can be a source of frustration. So, thank you. Any other questions?
Is
Yeah.
this the same then for same-sex couples?
I say yes, whether it's male or female, because some men are more of this type of responsive model, and for men there are varieties of reasons why we have sex. For female same-sex couples, I would say it's the same. For both of them, they could be responsive. For both of them, they may happen to both be spontaneous, or they may be different at different times. Sure. Okay, let's talk about communication too. So there's been lots of other studies going on. The two primary couples therapy models that are having the most success right now are Sue Johnson's emotion-focused couples therapy and John and Julie Gottman's Gottman therapy. I'm going to spend just a minute or two on the Gottman therapy because you can access the information a little quicker. You don't have to know some of the nuts and bolts like you do with Sue Johnson's work. John Gottman's a really fun, interesting fellow. He started his work back in the 70s because he was having trouble getting dates. He was a mathematician, so he decided to create a lab and study human beings to figure out how to get a date. So he and another fellow created this lab where they brought couples in and they monitored them for almost every humanly conceivable way. They hooked probes up to them. They set them in chairs to monitor how much they wiggled. They put them in apartments and videotaped them from day to night everywhere except the bedroom and the bathroom. They would sit and monitor them and watch them with groups of people studying them. And their studies revolutionized couples therapy. Before the Gottmans, couples therapy success rate was about a 50-50 chance, which frankly is about the same rate as no therapy at all. Their success rates are close to 80% for couples. And he became famous for being able to predict to a 90% accuracy within 5 minutes of meeting a couple whether or not they would divorce long term. So what they found in the lab was staggering, and then he met his wife, Julie Gottman, who is a therapist, and the two of them have worked together to come up with specific interventions based on what the research has shown works for couples to help them long term. What I want to talk about is just some of the basics around communication, And what I feel like can happen with any illness and with cancer included that can start to break down a relationship. So the main thing I want to talk about here are these levels of friendship. What the Gottmans found repeatedly over and over was that the quality of the friendship between the two people was the primary component for a long-lasting relationship. And they broke that down into 3 areas. The first one was knowing each other's world, how well you understand the ins and outs, even like, what does your partner like for dinner? What's your partner's favorite restaurant? What's your partner's favorite TV show? The mundane things, all of those things added up to a strong friendship. The other was sharing fondness and admiration, just verbally saying the things you appreciate about the other one. What they found in times of non-conflict for couples, that the positive to negative was 20 positive for every 1 negative. I thought that was staggering. I would have thought maybe 5 to 1. They actually found the ratio for couples who were not doing well. Anybody have a guess what the ratio was for times of conflict when couples were not doing well? That's pretty good. Yeah, it was like 0.8 to, who said that? Oh, I didn't see. Yeah, right, thank you. Yeah, it was, you're close. It was like 0.8 to 1. When couples who were doing well and lasted during times of conflict, it was actually 5 positive for every 1 negative. And that 1 to 2, where it's a little less positive than negative, over time, even when it's a small amount, adds up and deteriorates the friendship. The last one here, that 3rd level, is turn toward instead of turn away. Let's say, for example, somebody comes home to their partner and they say, "Wow, did you hear about the terrible accident on the freeway coming in?" The partner's looking at the newspaper or whatever and does not even acknowledge that something has happened. That technically is a turn away. Like you don't even hear what I'm saying. Let's say they come in and say, "Did you hear about the terrible accident on the freeway?" And the person says, that's actually technically a turn toward. It counts. It was good enough. If they show, wow, they actually turn the paper down and say, "Wow, you're kidding me. I had no idea. Are you okay?" Something like that. Wow, that is a really solid turn toward. So anything from to wow, you're kidding me. All of those add up in the plus column, that 20 to 1 plus column. And actually that makes a massive difference, because when you turn toward a person and they don't respond back, or you turn to a person and they don't know your world, or you don't even know if they like you, it starts to go from an environment of love to an environment of feeling like we're starting to live separate lives, or we're together, but I am really alone. And that is when it really can start to deteriorate for a couple. So I feel like with illness and including cancer, suddenly there are vast new areas of each other's worlds that you may or may not know about. Do you know what you're feeling? Do you know what your partner's feeling? Do they understand your hopes, your misgivings, your fears? How you have changed over time? All of that is part of knowing your partner's world. Sharing fondness, admiration. Do they still like you anymore after these changes that you are experiencing or have had? And those turn towards, when you're like, I'm turning toward you for comfort right now, or I'm turning toward you for fun or excitement or some sense of us going forward. Are they turning back toward you? And I feel like cancer and illness of any type can start to, maybe make the foundation a little different. One more slide on communication, and then I'll move on. When it is time to talk, this was the other thing they found from the Gottmans, was how couples manage conflict. One of the first things was a softened startup. So if they found that 97% of the time, if a couple started a conversation harshly, 97% of the time it did not end well. Only 3% of the time did it come out. So if somebody presents with, "What, are you not interested in sex anymore?" That's a harsh startup. So if there's a way to gently bring up the topic, the odds of it going well go up dramatically. The other is being able to accept your partner's influence. That's mean I can hear what you're saying and I can adjust my reality around you. The third one is dialoguing around problems versus gridlocking around problems. Rather than trying to convince you to see things the way I do so that you'll be perfect just like me, instead of talking that way about a problem, you actually explore the other person's world. What do you think about this problem? How do you feel about it? And is there a way to validate what the other person's feeling? Even if you don't agree with it, can you validate their viewpoint? And then the last one was practicing self-soothing. If you find yourself getting flooded and overwhelmed, just take a break, at least 20 minutes, not longer than a day, and try to get your mind on something else and come back when you've got your full faculties back with you. Mm-hmm. So you want to try to avoid criticism, defensiveness, contempt, and stonewalling. These were the things that they found. If these are in a relationship, these were the 4 horsemen of the apocalypse. That relationship was on its way out. The first 2, criticism and defensiveness, those happen with lots of people. Instead of a complaint, it's a criticism. Instead of something I don't like about the situation, it's something I don't like about you. That's a criticism. That naturally causes defensiveness when a person says, I don't have the problem, you're the one with the problem. The third one is contempt, and that's when you are really looking down your nose at somebody. There's actually sometimes a snarl involved with it. It's like that other person is kind of disgusting to you, off-putting. Sometimes sarcasm is a form of contempt. Eye-rolling is a form of contempt. And that one is so toxic to a relationship that they called it the sulfuric acid of the relationship, and that people who received contempt actually had weakened immunity in their body. So contempt is very powerful and damaging, and stonewalling is when you just shut down. This is stonewalling. So you've had it up to here with the contempt, the criticism, the defensiveness, and you just wait till the storm passes. You just shut up, keep your head down, and just wait for the other person to stop talking. So antidotes for all of that, or at least for most of it, is I feel this about this, and I need this. So I feel scared about the way we're not talking about my diagnosis, and I need us to sit down and talk honestly. I'm feeling angry because of the way my body looks, and I need you to just hear me without trying to fix me. So those are ways of trying to use that formula as a soften startup and try to rebuild a friendship. So really, if you remember nothing else I say about anything with communication, I would go for I feel X about Y, and I need Z on that. Yeah?
So how do you, and I'm guessing, because you're working with couples, if there's one person that really understands this, and there's another that the other doesn't, just because they weren't raised that way, that's just not in their toolbox. How do you help, I guess, train them or whatever to be able to use these words and approach it this way?
Could everybody hear the question? If somebody doesn't have these skills but you do. First, I would say try to use a gentle startup to broach the conversation. But I really appreciate that you use the word train them to do this. I know it might feel, and I was maybe iffy with the word training, but you're absolutely right, it's training. One of the things I don't like about Gottman is it's not really explaining why people talk the way they do, it's just explaining what people do. And their method is very much, let's get you to do what other people do that are having successful relationships and train you to do the same thing. And then when you learn to do it, then you'll succeed. I personally don't like that because it feels sometimes inauthentic and maybe demeaning a little bit to be told just act this way. But the research has shown it works. I use it with clients and I tell them that exact thing and they try it anyway and it tends to work and their criticism goes down and their friendship goes up. So there are books. I tend to like going to a book. The Gottmans, they have tons of resources. You can go to, I think it's just Gottman.com. and Gottman, and pretty much any of their books would be good. Their most famous book is 7 Principles for Making Marriage Work, but I feel like it's principles for making any relationship work. They're finding this is working for families too, not just couples, like that 5-to-1 positive and negative, 20-to-1 when things are going well. Yes?
I have a comment based off of your question, because I would be very difficult, and I had to learn to stop, arguing and better communicate. So I'm on this journey with my husband. He's not necessarily on the same journey. So he'll say, "You always do," and I get defensive, and then he's like, "You know what? You're right. I need to fix that." He'd be like, "Oh, she agreed," and then the whole tone of the situation would change. And so every time he has an issue, he holds it in, and then when it does come out, it's kind of big. So I'm like, when it comes out, I get defensive, and then he kind of mirrors, and it just has been kind of working as we kind of learn how to do it together without me like teaching him or saying, "You need to do this class too." Like, okay, I'll go. Like, I'm here now, then I'll go back and kind of do some of the things that you're teaching, and then it all kind of fall into place.
Well, I really appreciate you being open and sharing like that. The Gottmans called it the masters of relationships and the disasters, and you just very nicely showed us a master's level on that, because our partners do come out with things, and when it does sound like a criticism, this is the hardest one for me personally, but you try to just get enough space to pull down the defensiveness and say, what are you needing underneath? See, is there any portion of it you can agree with and validate? Even if you don't agree with it, you could say, well, from your side of things, I could get it. And you're absolutely right, it almost always de-escalates the problem. And then you're dialoguing and understanding each other versus, defending your territory. Thank you, yeah.
And there are also plenty of worksheets out there that are basic on empathy that you can bring to your partner and say, hey, can we just try this? I do this with my couples all the time, and they feel super awkward at first, and I'm like, just give it a try. And one person is the sender and one is the receiver, and then they just practice it. They just actively practice doing this. And initially in session, they may be like, this is weird. But they come back to me a week later, and they're like, actually, we pulled this paper out, we practiced it at home, and it was actually incredibly helpful and really great for us. So you can even research just empathy worksheets, and those are great and super helpful tools to just, for people who don't know how to organically bring that up, it's, all right, we have an instruction manual almost to follow, and we will stick to that, and it's great. I get great feedback on using those, so it's helpful too.
Yes, thank you for that. And it's different than reflective listening. Some of you might have heard of reflective listening, where somebody says it and you just say it back. What's better about the empathy, thanks, with that piece, is you're really trying to understand your partner's world. You're trying to see things from their lens. And once they feel understood, then they're able to kind of soften and hear you. So, and Julie,
Yes.
Can I push the button now?
Oh yeah, of
Okay.
course.
Okay.
You may, it's exciting. It's a good time.
Yeah.
Great. Yeah, so in line with communication, we really wanted to highlight some points of just even being in the doctor's office. What does it look like to communicate there? And so one of the things that we found in research is that many people, after they hear the diagnosis, you have cancer, they only hear about 10% of all the information that the doctor provides after that. And that can be really detrimental, because there's so much information that you could be receiving that you're missing just because you're in such a state of shock. There's just so many emotions going on. And so what we encourage is to bring somebody along with you, bring somebody who's going to be a support system. That can be really difficult at times to ask and be open and vulnerable and say, hey, I'd really like you to come along and be with me and be present. And can you take notes for me? Because I just may not hear, everything that's coming along. Or you can even ask the doctor, hey, can I record this session that we have together so that I can go back and listen to that information that you're providing for me, so that you're able to ingest it and just feel more well-equipped for moving forward. And that can be from the beginning to any point along at any appointment. There can be many times that people forget, questions that they want to have. And so just writing down questions in advance that you want to ask the doctor could be great. So it's really important. and just having things written down of, hey, I really want to know about how is this going to affect me. Even asking for some before and after pictures of surgery. I was doing some research and read a testimony of a woman who had to get a mastectomy, and she ended up getting a replacement, and she didn't realize how different her body would look. She was very quick. She got everything done within 2 weeks, and she was actually really surprised and scared by how different her body looked, the way it changed. And so it was great for her to say, you know, it's good to ask for before and after pictures of how is my body going to change? What can I expect that's going to look different? And so asking those questions and even bringing up the topic of sex in of itself, because we know that very often sex is going to change, whether it's because of the treatment or because of the actual organs that are affected by cancer. And so it can be a really awkward topic to bring up. A lot of people have a lot of discomfort around that. And so if there are any physicians in the room, I also encourage you to know that your patient is equally as nervous of bringing up sex as maybe you are. And so just making sure to take the initiative and know that your physician really would be more than happy to answer questions about sex. They might just feel a little bit awkward about it, and so you might have to take the first step into asking any questions that you might have or that you might want to know about. And then I also found in my research that many people hear from the physician, okay, well now you can go back to normal, that sex can just be, you know, back to normal, good as new. And many people are like, wait, what is, my life isn't normal anymore, like what does that even mean? And so asking for a lot of clarity of, you know, what changes can I expect over time? What changes can I expect in the first few weeks and the next 3 months? How about within the next year? What are you finding as a physician that people are experiencing in terms of changes that I can expect and I can be prepared for, and how can I prepare for that? So just a lot of great ways to be communicating, getting answers that you need in advance so that you don't have a ton of surprising news of, you know, all of a sudden you're in the bedroom and you get shocked by, oh, this is painful, or oh, this isn't what I expected. So it's nice to be, you know, prepared in advance rather than getting surprised later. So just encouraging you and really communicating and trying to ask questions and be open with your physician. And again, for any physicians in the room, just that reminder that this is an awkward topic for a lot of people to talk about. And so being willing to step out of your comfort zone and speak with your patients about any potential issues that they might experience for any side effects, not just, you know, typical physical things, but also sexually, because sex is a huge component of all of our lives, and we want to create comfort and security around that. So for women specifically, just some things that I wanted to touch on. A lot of women struggle with body image issues after surgery, feeling very uncomfortable with, you know, there are changes that, again, maybe that they didn't expect because they didn't see any before or after pictures, or just in general, there's just this feeling that, you know, my body isn't what it once was, and many women report not feeling quite like a woman anymore. And so there can be a lot of shame that they experience. And so I encourage you to definitely research a lot of work on shame. A lot of the things that we tell ourselves about our body, about our lives, will really affect the way that we tend to ingest that and start to believe it. It gets incorporated into who we are. And so a really great exercise that many sex educators and therapists encourage both men and women to do is go stand in front of a mirror, as naked as you can comfortably be, and write down all the things about your body that you like, the things that you appreciate, the things that you enjoy about it. And our natural inclination at first is to think about all the things that we don't like, all the social things that, oh, my body should look like this now, or it shouldn't be like this, X, Y, Z. But just set those aside. You can notice those, but then continue writing down those things that you like. And then do that the next day and the next day, and continue doing it every day, looking at your body, noting the things that you appreciate and love about it. And the more that you ingest that, the less that those negative messages penetrate you, and the less that there is shame around it. And so Brene Brown is a great author on shame as well. So if there's any shame that you might be feeling, knowing that it's very normal to experience that feeling, but that those bonds are very much able to be broken just by doing a lot of self-love and self-care, and really appreciating and knowing your body. And so again, just asking also for some before and after so that you're not super surprised by any changes that may occur. Just creating some awareness for yourself in advance. And again, you might be a year in this process, but still ask, are there additional changes that I might expect down the road so that I can be mentally prepared and not have a huge shock when anything happens. Asking about any hormonal changes and things that are available after any sort of procedure. We did get a lot of questions about estrogen and how, can I do a suppository? Is that okay? Things like that. I'm not a medical professional, so for some women, absolutely estrogen can be a great help in terms of getting your body, getting your vagina moist again, softening those walls, creating an ease when it comes to intercourse, but that's not true for everyone. And so I encourage you to definitely ask your physician, is this right for me based on the procedures that I've had? If not, what are some other options out there? And so different, that might be on my next slide actually. I'll touch more on just some things that you can do in terms of sex if estrogen is not an option for you. But another thing is asking the doctor about, again, how is radiation or chemotherapy going to affect my body? So not only all those physical changes, but there could be loss of many people I've found didn't realize that not only will they maybe lose hair or eyebrow hair, but they're gonna maybe lose pubic hair. And some women can have a hard time with that because they're like, I don't feel like I look like a woman anymore. I don't feel like my full femininity. And so being prepared for that to happen, any sort of tissue damage, how can I be proactive in supporting my body for any changes that may occur. And I'll talk again about some more tips and tricks in terms of when it comes to sex, how to work with some painful intercourse issues. Yeah.
You talk about being prepared, seeing before and after.
Sure.
I saw before and after, but that didn't prepare me for how it was going to feel to be inside that body.
Yeah.
Once you had that after body.
Right, absolutely.
And you talk about standing in front of the mirror and saying, what do I like? Well, how do you get to a point where you start to like something again?
Absolutely, that's such a great question. And to your point, just because you see the pictures doesn't mean that you're prepared for how your body is going to change and how that can affect you. So that's a great point. And so the more that you practice that practice of finding things that I like, the more again that you're going to ingest that and start to believe that. And I actually had somebody mention that their partner, because they themselves weren't able to see things that they liked, their partner would take pictures of them very kind of sporadically when they're just going about their day, and they would say, look at how beautiful you are here, look at you here. So even having a partner support to point out these things, these beautiful parts of you that you may not feel like, I feel beautiful, but then your partner is there to support you and say, absolutely you are. And again, just doing a lot of that self-work. If standing in front of a mirror you don't see anything that you like, I think just continuing to reach out for support from other women and say, how do I move past this? How do I get to this place where, what did you do to feel truly beautiful? And so for some women, that means I've had even women do something so fun as they did body paint all over their bodies, and they just created this beautiful art on themselves. And they were like, this feels beautiful to me to be able to express my body in a way that's creative and different. And I'm fully covered these beautiful colors and shapes that are expressive of me. And I'm able to appreciate my body in this light until, in the future, the more that I do this practice of noting things that I like, the more that I note these things, the more that change will start to occur. So it's definitely not an immediate change, but it's definitely something that the more that you practice it, the more that you speak these truths over yourself of, I am beautiful, these are parts of me that I do love, and getting support from others, that will eventually get incorporated over and over until you start to really accept that as truth. So at the beginning, it's definitely hard, but the more that you work at it, the more that you practice it, the easier it is to start to believe those things.
Can I say something?
Absolutely.
Sometimes it's really hard to say that when you had your breasts cut off.
Absolutely.
You have so many drugs and you're swollen up and you look like a Goodyear blimp.
Yeah.
The best thing to say, honestly, is it will pass. And you just want to be so thankful for your body for taking you through that. And it's just, the body can fail you on the outside, but the inside and the heart and everything else, It will pass.
Mm-hmm.
I was
Clearly,
looking in the
I'm at a
mirror.
point where I'm just coming out of things.
Mm-hmm.
You know, you look in the mirror, you have no eyebrows, you have no eyelashes,
Mm-hmm.
you have no hair. And it's just really tough. I don't care
Mhm.
how many questions you ask or what you did.
Mhm.
I mean, you're stripped down to nothing.
Mm-hmm. Yeah, and that can be so hard. And I love that comment and that beautiful honesty of, you know, externally things may not be the same, but being so thankful for your body and that it supported you and brought you through that journey, and just being grateful for that. And I love that even that notion of that it will pass, that it takes time, that it's not immediate, that these things, I mean, this can be so tragic at times for people to experience a full body change, and knowing that it truly does. It takes time, it takes support and encouragement from others, and we'll talk about some resources that you can lean into for that support as well. But absolutely, that can be very, very challenging. So thank you for that comment and that feedback. That's so great.
Go see Dr. Chen, she does wonderful work.
Oh, good.
Dr. Chin is my doctor.
Oh, perfect. Yeah.
I'm new to the area. Dr. Chen?
Yeah.
Dr. Chin.
Yeah. Plastic surgery, reconstructive surgery?
Yes.
Okay.
Oh, good. That's great. And I don't know if
And
you have
I
any
wanted
other
to
thoughts.
Yeah, I was thinking too, what I feel like is the literature I've looked at, I feel like it was massively helpful, and what I felt like was maybe missing a bit was some of the grief, talking about grief. I tend to want to go straight to acceptance, and I want to skip the, it's not just the denial, anger, bargaining, depression, acceptance that's kind of in the swing now. There, you know, that Kubler-Ross method, that we know more about grief now. There's shock, there's this numb feeling, then there's this onset of emotion and depression, and then you get bouts of anger and stabbing memories, and all of those things can just loop around, sometimes from minute to minute. And when you see these things, it is different, and I do feel like it's stages of grief. And eventually there's acceptance, and at the long end there's resurrection. And even if somebody's not from a Christian background, you can still see it in that story with Jesus when he came out of the tomb. He still had his scars. You know, there was something, you know, he's there, but he's moving in and out of walls now. He's there, he's the same, and he's different. There's still this evidence of being wounded, but there's still something new. So I feel like, I don't know, I appreciated it. The way you said what you said, it made me think you were farther along on that journey. I don't know, I might have been reading too much into that.
Mine's been like 2.5 years, so I'm finally at the end of it. But
Yeah, and I think for me, you go into this and it's wham bam. It's like you have cancer, you're going to have surgery, you're going to have chemo, you're going to have this, you're going to do this, and you don't have time to grieve. And I think that's probably where I'm at. Because it's like you have time for nothing. It's like at one point in time, I think I had a doctor's appointment or some procedure every 1.5 days. You know, and you've got all this stuff going on. There's no time.
Yeah.
And I never thought about it as grieving until you mentioned
Yeah, that's such a great point.
That was in the literature too. Sometimes with all of this, the parts are all the moving parts are moving so quickly that it's not until sometimes after treatment that the dust settles, and you that's when the depression kind of settles in. People are like, "Oh, shouldn't you be happy now? It's over," and you're like, "It's the first time I've had a chance to come up for air." A couple other hands
That's
went
how
up.
I feel afterwards. It was so fast that now, since I went through all that process, I feel like I don't have a doctor's appointment, I don't have this. Now it kind of hit me now.
Yeah, once everything's
Everything what
settled.
she said was like boom, 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 boom. Make it to this stage, and then now it's like, where I go from here?
Yeah, right.
Somebody turned it back on me. Like, where should I go from here? Like, you're okay. Come back 6 months. Come back in a year. You know, that kind of hit. You don't have nobody watching you, or look and see what's going on with you in your body. So it's kind of like depressed now.
Yeah.
Yeah, and I think with the prolonged nature of it all, that initial shock, like when a sudden change or a trauma happens, you get that initial shock and numbness. And this is layers of shock and numbness. Like you get, there's treatment after treatment or change after change or layer after layer. And I feel like it just takes time for all those layers to get peeled through or surface. I don't know the right word for it. One last thing I'll throw in too, and I hope I didn't overspeak for you when what I was saying before. It feels like with grief, as the dust starts to settle, it's hard to know the right words for it with grief, but once the dust settles, it's not the same person as before the dust got kicked up.
Right. Yeah.
And it's like it's you, but it's somebody new too. So, for men, yeah, many similarities is with women. You want to, if you can remember, please bring somebody with you to the doctor's office or ask if you can record it. That's a lot easier now with the phone because we do go into these shock stages and we miss a lot. Write down your questions. You have the right to know about all of your treatment options and the consequences of those treatment options. And that includes the sexual consequences. And again, to reiterate what Julie said before, research shows most doctors are open to talking about sex with their patients. They're waiting for their patients to bring it up. The patients are open to talking, but they're waiting for their doctor to bring it up. So you have the right to ask. Like we said, you can ask to see before and after pictures. Maybe it'll help, maybe not, but might take at least one layer of the shock off. And don't compare your treatment options with that of another person, even a close family member. You know, my dad had this treatment option. This is what was best for him. That might have been 20 years ago. So treatment options could have changed. And also, the consequences of treatment options might be okay for one person, but they might not be okay for you. So somebody might be okay with this option for prostate cancer. Somebody else is like, I can't live without that. I need a different treatment option. So this is...
So sex, yeah. What we're all here for. So in terms of some helpful tips for sex, now again, a lot of people have a lot of, different types of cancer, different types of treatments. So we'll do our best to speak to as wide of an array as we can. If you have questions, of course, at the end, we'll give you that opportunity. We'll do our best to answer them. Worst case scenario, we might say, hey, we'll give you some resources that might be helpful for answering your questions. But first things first, just one helpful tip for women especially is that lubrication can be very helpful, especially for those who can't use estrogen for helping to create more moisture in the vagina or the vaginal tissues broke down. So lubricant can be very helpful for that. So there are 3 different types of lubrication out there. There's oil-based, there's, what did I say, silicone? Silicone and water-based. And so each have their own benefits. So silicone-based is really great. It's very smooth, it's very slick, and when all is said and done, it tends to dissolve into sort of like a powder, whereas with other lubrications, it can kind of leave a residue. So it's a pretty quick and easy cleanup sort of situation. The only thing with silicone lubrication is that you don't want to use it if you're using toys of any kind because it can break down the silicone of the toys. But otherwise, it provides a lot of great smooth lubrication, moisture. So very basic KY jellies, things like that are very common, typical, great for use. Oil-based lubrication is also great, especially if you want to be really kind to your body in terms of maybe using something more natural like olive oil or coconut oil or something like that if that feels good for you. The only thing to bear in mind for that is that can break down the latex of a condom, and so bearing in mind just the effects of the different types of lubrication that you're using. And those can tend to dry up a little more quickly, so you may just have to be a little bit more diligent about replenishing it as needed. So being in communication with your partner of, hey, things are starting to feel a little bit dry or uncomfortable. Can we just like apply a little bit more lube as we go on? And the last one is water-based lubrication. It's really great for the prevention of yeast infection. So if your vagina is especially sensitive to getting that, water-based is a really great way to go. You can use that with toys, you can use that with condoms, anything of that nature. The only thing is when it's over, it kind of leaves like a sticky sort of gushy leftover residue. So cleanup is just a little bit of extra maintenance at the end of that, but that's very easy with a shower or just, a wet wipe or anything like that. But lubrication can be very helpful when engaging in sex, when the vaginal walls are just feeling very dry or there's discomfort, that can really create just a more comfortable experience overall. So that's really helpful. Tips and tricks for managing an ostomy bag, if anybody has that, or even with a mastectomy or anything of that nature, wearing nice negligee that makes you feel really sexy, makes you feel really good, anything like that. Or you can, wrap a scarf around the side if you have an ostomy bag just to cover that up a little bit, but still provide, other, body images that your partner can see. So just being creative in how you present your body in a way that feels, good and comfortable to you. So again, accessing negligee or using a scarf, something that's, soft and comfortable and still makes you feel that, that you're as free as you feel that you can be in that. Also, dilators can be very helpful for women. I suppose maybe this might have been helpful tips for sex for women, and I may just not have added that at the end. But dilators can be very helpful, especially because during treatment, sometimes the vaginal walls, again, can start to come in and start to shrink a bit, and so sex can be painful, penetration can be uncomfortable. And so dilators, you can buy them as a set, and they start out really small, very, very small. They look like a dildo, but just a very much smaller version, and they gradually increase in size. And so what you would do is you would insert the smallest one, just practice relaxation and letting your vagina relax around that for a little bit, and then progressively move up to the next size, the next size, the next size, till it gets to about the size of a penis. They actually do it a little bit larger so that when an actual penis inserts it, it actually feels a bit more comfortable. And that can help just with the relaxation and reopening of the vagina if there's been any sort of collapse or any sort of closure. And with those, you definitely want to use lubrication as well, just to allow for that easy access. So that can be very comforting as well. Utilizing different toys or positions if intercourse is too painful. Sometimes actual intercourse, if that's the type of sex that you would engage in, can be painful, or for same-sex partners, utilizing toys can be very helpful as well. And so some women find that penetration is too much, but we can use a vibrator. Jack mentioned that about 70% of women need some sort of clitoral stimulation, so utilizing a vibrator or something of that nature can be very helpful. Or there are other positions that one can utilize, and we have a book that has some resources for that. But for instance, you could lubricate your thighs, and your partner could put his penis between your thighs, and you still get that same closeness, that same feel with the lubrication, but without actual penetration. And some partners find that to be very helpful, very nice. As a supplement for intercourse. Engaging with your partner even when you don't feel aroused, and this again with Jack, when I say no, I mean no, like that, cling to that. But there's definitely research that says with that whole model that we saw that many people aren't spontaneous, they're a bit more responsive. And so maybe just if you're wanting to engage with your partner and you kind of want to test the water, maybe they do say they're 4 or 5. So maybe just start with a massage of some kind, or start with going on a date or doing something that could increase arousal. So, your partner might not initially feel, super aroused, but by engaging in these lighter activities that could help bring them into arousal, that could, many people find that just even those beginning stages can help move them into arousal. So just being gentle with yourself, but also acknowledging, again, if I'm not feeling it, that's okay, and I don't have to engage in that right now. And then communication is the biggest key with all of this, and Jack provided a lot of great tools for communication, but definitely sharing things that you like and that you don't like. There's great research by Emily Nagoski from this book that's called Come As You Are, and it's all about the female orgasm. And she talks about how everybody has a set of brakes and accelerators. And so accelerators are going to be things that turn us on, that make us want to engage in sex. And so that can be, any sort of stimulating activity that would make us feel more excited. But then there are breaks that people don't consider and that are actually very important when it comes to sex, and that can be stress. Stress is a major break that says, whoa, no thank you, like I'm not into this right now. Or, you know, I have so many other things that I need to be taken care of right now. I have all these doctor's appointments that I need to manage, or I have medication that that's just not making me feel well, all of those things. So being very communicative with your partner of, here are my accelerators, but here are my brakes, and how can we decrease some of the brakes that are happening so that maybe my accelerator can be engaged a bit more. So again, being very open with your partner, you know, just communicating with, this is what I need in order to feel comfortable, to feel more turned on, or being very honest of, I don't feel like I look the way that I want to look, and I'm scared for how you're perceiving me, and allowing them to speak honestly back to you can really open up a lot of great communication, a lot of great conversations. And so again, this is just kind of a big general overview, because there are many different effects that can happen with sex, but do we have a slide after this, or should I ask for questions? We do? Okay, then I'll let you go, and then we can have questions about sex. Oh, good. Okay, great. Yeah.
For men, remember, and for those with male partners, remember you do not have to have an erection to have an orgasm. Some men are really surprised to learn this. Specifically with prostate cancer, when those nerves are cut and the man loses an erection, those aren't the same nerves that are connected with orgasm. So after a prostate cancer support group a few years ago, one of the men came up to me afterward and he said, you know, I had my prostate removed years ago and I've been having a great time. He said, I just get my vibrator and my porn and I'm doing great. And that was working for him. So he was having a good time. There's also an interesting book. It was like 6 tips from women who are lesbians for everybody, something like that. But for women to women partners, there's no penis involved and they're enjoying each other's bodies. So that's a great lesson for men too. You don't have to have an erection to enjoy pleasure with each other. If you're using an androgen blocker or if you're low in testosterone, try setting a reminder to be physical with your partner. It's going to be off your radar if your androgen is just, if the testosterone is totally off. You won't even remember to give them a hug. So even something like when the nightly news comes on, I'm going to go sit by my partner and hold my partner's hand. So you're actually just using external cues to remind you. Clothes, as Julie was mentioning, can be helpful for men, not just women. You can use a cummerbund or some nice, silk pajamas, something. It doesn't have to be just, some old baggy work shirt to cover the ostomy bag. You can sex it up a little bit. Talk with your doctor about certain short-term changes that can be helpful. For example, you might have a cover that you could put over the stoma for a short period of time while you have sex that could be taken off later and then reconnected. And like androgen blockers, sometimes, I know I'm talking a lot about prostate cancer, that's the one I'm the most familiar with, but if the PSA level is brought down to a certain level, sometimes the doctors will switch off your androgen blocker and monitor your PSA. So there's a way you can get a jump in testosterone for a short term. And then sometimes medication shifts. With cancer, it's not uncommon to feel depressed. You've been through so much, sometimes just even the drops of testosterone will cause depression. So you might go on an SSRI, like Lexapro, Paxil. Those have notorious sexual side effects, including decreased libido. So you might feel better, but you might not be in the mood for sex. So one example of a medication change might be adding some Wellbutrin, because Wellbutrin will increase dopamine, and dopamine will increase sex drive, and sometimes that will offset the side effects of a decreased sex drive. Some people will report an increase of sex drive with a dopamine, a drug that increases dopamine, like Wellbutrin. The other thing about, it doesn't have to just be a drug. Anything that will increase dopamine could also potentially increase sex drive. It can override low testosterone. So variety and surprise are the 2 things that help us with dopamine. That's why a lot of couples report having great sex on vacation. They're relaxed and they're doing something new. So they're relaxed with a nice dopamine hit. So suddenly they're more in the mood. And you don't have to go on vacation for that. So you can try that. Talk with your doctor about penile rehabilitation. Sometimes if you're having some type of procedure that causes loss of erection, you have to try to get an erection 2 to 3 times per week in order to get blood flow and nutrients into the penis. When that doesn't happen, sometimes there can be long-term loss of erections. But the most recent research is still even a little controversial on penile rehab, if it works or not. If your doctor does think it works, you can talk with your doctor about options, including like Viagra. That works for some cancer treatments, not for all. Other things, I don't know if you can see the small print here. Compression rings, those are kind of like a cock ring. Those would go around the base of the penis and help restrict blood flow to help ensure an erection. Penile vacuum pumps, where the blood is drawn into the penis and then there's a ring that's placed around the penis to hold the blood in. The penile injections, it is what it sounds like. It is a needle about the same size that's used for insulin that is injected into the penis. It will guarantee an erection. Regardless of what's happened, the man will get an erection. It sounds horrid. I've seen videos of it. It looks as bad or worse than it sounds, and yet I've heard from men that they really like it. Because once you get over the initial shock of putting a needle in a penis, the results are quick, it's effective, you don't have to sit around and wait for a pill to work, you're not fumbling with something mechanical, the meds stay in your refrigerator, you just go get a needle, some couples incorporate it into foreplay, and then you're up and going with the guaranteed erection for about an hour. So the last one that I have there is intraurethral pellets. It's a little pellet that you would stick in the urethra. That to me sounds worse than an injection, and that one does burn, but you get an erection. So, and lastly, condoms are not just for birth control. So a lot of times men will have a lot of embarrassment around incontinence, so they avoid sex. Or they think, if I touch my partner's going to think I want sex, so I'm going to fail if we go towards sex, so I'm not even going to touch my partner, and they shut down completely. But with a few small tricks, like maybe we go in the shower instead, but for the start of foreplay, let's go take a shower together. Then if you're incontinent, nobody really notices. Or you have sex with a condom, and if there's a little bit of leakage, it goes into the condom anyway. So.
But just some great resources that are available. Jackie,
I love Ann Katz's work. She's worked as an oncology nurse and has worked specifically with sexuality. Woman Cancer Sex is a fantastic book. That's her most popular. Man Cancer Sex, and then one specifically for prostate cancer and the man you love. Any of her work I think is great.
And then there's the Guide to Getting It On with I can never say his last name right, Joanides, I think is how you say it. But his book is probably like this thick, and it's everything and anything you could possibly want to know about sex. And so he has great positions, great just feedback. He does address cancer and sex and different options that are available and out there. But it's just a great book for like any and all questions you might have about sex and just different tips and things of that nature. It's a really great book for just getting all sorts of resources available for you.
Sexuality Resources at a Woman's Touch, that's not just for women, that's also for men. And you can click on and find free brochures. So for example, back to that comment about you don't have to have an erection to have an orgasm, there are some specific brochures around that. So for example, if a man can't have an erection, there are ways he could use like a harness with a dildo attached that also vibrates so that he could get stimulation of his genitals while his partner also gets stimulation. So it's ways to think outside the box, and some free pamphlets on that.
Yeah, and especially finding support groups is going to be really helpful as well. Again, finding others who have gone through this experience, who can give just their own story, share their own experiences, share their own tips and things that have happened for them, things that have worked well, things that maybe didn't work so well, and how you can avoid that is going to be really great. So these are just a couple of resources here. I'm sure these ladies can speak to that as well in terms of some support groups that are available. But yeah, so it is going to be a huge component in terms of that healing process, is finding just support from others who have had a similar experience as well.
And one last thing that I feel like could underlie potentially everything we've talked about is a feeling. And I feel the strangest of all the feelings. And it's a feeling we have and can often have without knowing we have it. We can call it lots of other things and not realize it's the feeling word we're having. Until we name it, and I think it's the word shame. When we feel shame, it's like we feel like we're inadequate, we're broken, we're somehow different, we're set apart, we're lonely, isolated. And I feel like shame is so destructive, and it is so pervasive in everything we've talked about. These sexual models that we think tell us what's normal, that tell us our bodies are bad because they're different and not quote, normative. And I think if we can spot the shame and offer compassion and love back to it and talk back to it when we can, I would encourage anybody to do that. And shame when our sex is different than it used to be. Part of the grieving is letting go of an old sexual script to try to embrace a new sexual script that could also be as pleasurable, maybe even more pleasurable, if people are suddenly now talking and communicating in ways they didn't before.
That's so true. That's great. That kind of hits on our summary. Yeah, so I would say everything that you said, and just so that point on shame, but just again, communication with not only your doctor, but with your partner, and again with yourself when it comes to that shame component. What am I feeling? What's happening in my body? Where am I feeling that feeling? If I could, if you can just go inward and really hone in and be communicating with yourself about what's happening for me. So communication with all sorts of people. So again, knowledge is power, making sure that you are accessing those resources, asking questions, getting information that you need, and really thinking outside the box, like Jack mentioned, of just getting creative. What are different things that I can do, that we can do together, that can really create positive change for us?